Hi everyone, welcome to researchmd.com. We got another great topic today. Today we're going to teach you everything about gastroesophageal reflux disease under 9 minutes. So make sure you repeatedly watch so we can stay in our memory for a long time. Again, my name is Pramil. I'm a program director, internal medicine residency, transitional residency, and I'm also director of research and teach medical students and residents on a regular basis. So let's get into our topic. Gastroesophageal reflux disease. What happens? We got acid reflux. It can also cause heartburn, regurgitation, can cause like esophageal injury and kind of related complications. There are two main types. One is called NERD and ERD. The main difference is like NERD, just like it said, it's non-erosive reflux disease. So esophageal injury is like less, and the erosive reflux disease, that's where the esophageal injury and the complications can happen. Epidemiology prevalence is very high, 15 to 30% in the US, increases with the age. Let's look at some of the mechanism, like what causes. Mainly got gastroesophageal junction dysfunction, okay? The following factors can be contributing it, right? One, increased frequency of transient lower esophageal sphincter relaxations, and then you got imbalance between intragastric and lower esophageal sphincter pressures, and then you can also have anatomic abnormalities of the gastroesophageal junction. Now, what are the risk factors? You got smoking, caffeine, alcohol consumption, stress, obesity, pregnancy, iatrogenic, and inadequate esophageal protective factors like saliva, less saliva, peristalsis, and GI malformations like tumor, gastric outlet obstruction, gastric cardiac carcinoma, scleroderma, sliding hiatal hernia, and asthma. And all of these are the main risk factors, okay? Now, what is the usual presentation? Retrosternal burning or heartburn, right? Regurgitation, you can have dysphagia or dinophagia. Water brush, symptom of excessive salivation triggered by reflux of the stomach acid. Atypical symptoms could be like a pressure sensation in the chest, belching, bloating, dyspepsia, nausea, and halitosis. And you got esophageal symptoms like sometimes, chronic non-productive. So if a patient comes to you and say, like, you've been having chronic cough for a long time, always kind of think about, like, gastroesophageal reflux disease could be one of the reasons. Hoarseness, dental erosions can also happen. So the main thing, how do you investigate it? You go for EGD, right? When you look at the EGD, it could be erythema, edema, friability, erosions, especially erosive esophagitis. You got mucosal break, ulceration, peptic strictures and rings, and salmon pink mucosa. That is a bad sign. You got like Barrett's esophagus, okay? And the proximal migration of gastroesophageal junction Z line, that's mainly in Barrett's esophagus, or it could be also in hiatal hernia also. Now, esophageal pH monitoring, this is the gold standard, okay? It can be used to objectively identify abnormal reflux of the gastric content into the esophagus. Measurement of esophageal pH, what do they do? Like over 24 to 48 hours, using a telemetry capsule or like a transnasal catheter, drops in esophageal pH or 4 less, that correlate with the symptoms of the acid reflux and the precipitating activities, okay? Again, remember, esophageal pH monitoring is the gold standard. Then you have like esophageal manometry. So test used to measure the function of the lower esophageal sphincter. Consider if achalasia or esophageal hypermotility disorders are suspected. You can do like barium swallow. If the mainly if you do like there's a dysphagia and there's like a structural abnormalities, okay? Now, is this a very, very important slide up here? Everything we do, we just always say like, what's the sensitivity and specificity of it? Look at it. Sensitivity and specificity of 96 and 96% where? 24-hour pH monitoring. Again, that's a gold standard, remember that. And what are the management? How do you do it? The management, dietary recommendation, like small portions you eat, avoid eating at least 3 hours before bedtime, avoid food beverages that appear to trigger symptoms. We talk about alcohol, smoking, weight loss in patients with obesity, nicotine, alcohol, caffeine, and if the patient experiences a correlation of symptoms with that. Medication, some of them calcium channel blockers and diazepam and all that. And sometimes it's a good idea to like lift the head of the bed, maybe put some bricks under the table to lift it up, so less symptoms. Pharmacological, mainly we know about proton pump inhibitors, right? Standard dose for like, you treat for like 8 weeks and then see the symptoms better. Like, let's say if you are like refractory, it's very bothersome and there's no, we tried everything, then you have to look for like, what are the surgical options? There's like a nice picture of what do they do, like something called a fundoplication, right? It's an anti-reflux procedure. Gastric fundus is wrapped around the lower esophagus and secured with the stitches and make like a cuff. You can see that clearly. results in a narrowing of the distal esophageal and the gastroesophageal junction, preventing the reflux. So the cuff is formation and then prevent the reflux. Very nice picture right there. Now, what are the main complications of gastroesophageal reflux disease? Barrett's esophagus, all right? Intestinal metaplasia. You got the cellular mechanism is kind of changed into like a more malignant type. Chronic reflux, you got normal squamous epithelium into columnar epithelium, a pre-malignant change. That's what, those people made it like frequent endoscopy, which we'll talk about, maybe another presentation. So that's a bad sign, Barrett's esophagus, okay? Esophagitis, most common complication of gastroesophageal reflux disease. And then you can have mucosal erosions, alterations. Mainly you can also have like esophageal stricture. And these are our references. Thank you so much for watching. We'll be back with another presentation soon. Thank you.